Today, we will get into the world of the abnormal fetus. This patient was scheduled for a routine follow-up sonogram, but a striking abnormality was noted. In these two images, we see severe scalp edema on the left and ascites and probable polyhydramnios on the right. Note that the torso does not fill the amniotic cavity from front to back. In these circumstances, it is appropriate to measure the thickness of the placenta. We see here that the placenta measured 42 millimeters. This is data I gathered many years ago. It shows that abnormal placental thickening differs with the age of the gestation. However, placentas greater than 4 centimeters are virtually always abnormally thickened. The importance of placental thickening is that it can result in the mother also getting ill, and at times very ill. It is sometimes called the, quote, mirror syndrome, wherein the mother starts to develop symptoms mirroring her fetus. It is too complex an issue for this teaching session, but you should be aware of it. Additionally, the fetus demonstrates bilateral pleural effusions. And finally, we confirm our suspected polyhydramnios. Notice that the amniotic fluid index is 32.7. Recall that I personally never diagnose polyhydramnios without a number to back me up, whereas if my eye tells me it's oligohydramnios, you can't talk me out of it with a number. And that is, of course, because oligohydramnios is much more dangerous than polyhydramnios. Notice that the weight is greater than the 90th percentile. That, of course, is a wet weight. It is not the actual fetal weight. And recall that the abdominal circumference is much more heavily weighted in the Hadlock formula than our other fetal parameters. And, of course, the ascites increases significantly the abdominal circumference, which therefore is increasingly manifested in the abnormal weight prediction. If we look at the percent change in predicted weight compared to the percent error in a given measurement, we see that at 10% error in measurement, there's maybe a 2% change in the weight prediction. At a 10% error in the femur length, there's probably an 8% error in weight prediction, and a 10% error in abdominal circumference results in about a 15% error in weight prediction. And these only get significantly greater with the increasing error. So what conclusions have you drawn? What conclusions are we doing together? Well, this is a case of Hydrops fetalis. To diagnose Hydrops fetalis, there should be fluid in 2 fetal compartments. And of course here we can say that there was fluid in the pleural cavity, in the peritoneal cavity, and there was excess fluid in the amniotic fluid component, also placental edema. The fetus demonstrates every feature of Hydrops fetalis except the pericardial effusion, so ascites, pleural effusion, integumentary edema, placental edema, and polyhydramnios. There are 2 types of Hydrops fetalis, or perhaps we should say subtypes. That is the immune Hydrops fetalis and non-immune Hydrops fetalis. How do we discriminate between these two subtypes? The answer is that we do an indirect Coombs test on mom's blood to screen for antibodies indicating that she has a blood group incompatibility. The most common, of course, is Rh isoimmunization. There are innumerable causes and associations of non-immune Hydrops fetalis. Leading the list, since Hydrops fetalis you can think of generally as being heart failure, it should be no surprise that a bad heart is a principal cause of non-immune Hydrops. So fetal cardiomyopathy, severely malformed hearts, cardiac tumors, arrhythmias, inflammatory diseases of the myocardium, all of these result in non-immune Hydrops fetalis, or can result. Then there are genetic disorders, including trisomies, Turner syndrome, and the hypokinesia syndromes. Fetal anemia can be caused by infection like parvovirus, but then we have others like alpha thalassemia and fetal hemorrhage. Infection, in addition to parvovirus, we have the torch group of infections. In twinning, we have the twin transfusion syndrome, usually affecting the plethoric fetus, the recipient twin, but it can also affect the donor twin, again, because of anemia. And then the trap syndrome as well. Then we have thoracic masses, such as the congenital pulmonary adenomatoid malformation, congenital diaphragmatic hernia, teratoma of the mediastinum or pericardium. And then vascular tumors, particularly vascular tumors that have arteriovenous fistulas, which can put a high stress on the heart. Sacrococcygeal teratoma, SCT, is the most famous among these. And leave us not forget that no matter how you aggressively pursue finding the cause of non-immune Hydrops fetalis, there's always going to be a significant cadre of patients where you cannot figure out exactly why this particular fetus developed non-immune Hydrops fetalis.